All right, so transport, let's move on. As we've been talking about, that's one way to impact hormone balance is how is it transported. This is what sex hormone binding globulin actually looks like. And you've already seen this slide. This is one you might want to laminate and have nearby. It will help you remember what moves sex hormone binding globulin up and what decreases it. Everything that we'll want to do for the average woman is the opposite of what Mark wants to do for his men, okay? Because generally speaking, we want more sex hormone binding globulin to bind up the excess estrogen. And for that, it's low-fat diet, low-protein vegetarian diet actually increases sex hormone binding globulin. The things on the right will decrease it, and if you decrease it, then obviously you're going to have more estrogen and potentially more of an imbalance. So what's really funny, I mean, think about some of the patients that may come into your practice and they're doing everything, they're trying to be healthy and they're doing everything wrong. Like they're doing what they think is a paleo diet and they're doing it really poorly and it's really more like an Atkins diet. So that's actually making their estrogen worse because it's lowering their sex hormone binding globulin. They have hypothyroidism that hasn't been treated yet, so that's making it worse. You can just go down the list. Just a little aside, if you happen, I mean, generally in my case, I will have already checked their insulin, but if you have a sex hormone binding globulin level that is less than 40, assume that that person is insulin resistant. If you happen to find a super high one, like 120 or more, it might be from a medication, but also consider it's a toxic burden. And so that may be somebody that you'll need to think more about detoxification and put that higher on the priority list. Sex hormone binding globulin list is in your toolkit to remind you how to handle this. You will be surprised. If you haven't already looked at the toolkit, you'll be surprised at the great stuff that's in there. I still periodically go back in and say, okay, what was I forgetting I can use? Now, sex hormone binding globulin is not the only protein that's elaborated by the liver under the influence of estrogen. All of these other things are as well. So corticosteroid binding globulin, thyroid binding globulin, clotting factors, you name it. This is a good time to make a quick comment about oral contraceptives. Now, are they good contraception? Yes. Are they generally easy to use? Yes. Are they potentially problematic for some people? Mm-hmm. Oral contraceptives increase all binding hormones because they are oral estrogen-like hormones. They're not estrogen, but they act similar. They're going to add to the total body burden. Over time, they affect thyroid hormone function. Now, in my generation, we started birth control pills at, I don't know, 15, 16 maybe, but we were getting off of them in our mid-20s because, you know, we had babies a little earlier back then. Well, nowadays, kids are starting birth control pills when they're, I don't know, 12, 13, 14, and they're staying on them for 2.5 decades. I think that's a different situation than only, 8 or 10 years. This is also going to increase the risk of gallbladder issues, autoimmune disorders, and of course they deplete a lot of nutrients. So when I have a conversation with young women about contraceptive options, obviously this is still something they may want to do, but they need to be aware of the potential downsides, especially if they're pretty young and they're planning on being on them a really long time. They will look at you funny when you have this conversation because everybody they know is taking the pill and they just go, yeah, give it to me anyway. But at least they're aware. Now, this is from a study on the effect of oral conjugated equine estrogens, in other words, Premarin, versus transdermal estrogen on different hormones and binding agents. And you'll notice that pretty much all of the binding agents, they've just gone crazy. Sex hormone binding globulin goes up, which means there goes your free testosterone. TBG goes up, so you drop your free testosterone. If you're free T4, I'm sorry. The cortisol levels change. Pretty much everything changes when you do oral estrogens, which basically means I don't really use a lot, and most of the people in functional medicine in a faculty, we really don't use much oral estrogen. Sensitivity. Got to work on how can we make the cells be more sensitive to the hormones. Now, These are different xenoestrogen structures, and when you mess with the front end, it doesn't fit in the lock as well as when you mess with the back end. So basically, these are different things that this next slide might make it a little more clear. Estrogen and isoflavone. Isoflavone is one that you may want to use therapeutically because it doesn't have any downside and it can fill up the estrogen receptors if you're trying to sort of block them. But just be aware that these other non-estrogen structures can be part of the picture. To remind you about estrogen receptors, there's two kinds, beta and alpha. There may be some others, but these are the two that we are talking about these days. Different body parts have different either estrogen alpha or estrogen beta. Some of them have both. The thing to keep in mind, and this is quick, easy mnemonic, the alpha is the accelerator, the beta is the brake. So beta estrogen is more your friend if you're trying to keep estrogen balanced. And it also means that any body part that has alpha estrogens is going to be potentially more of a problem. And unfortunately, breast and uterus, well, breast has both. So that's an issue. So does the uterus. So now detoxification. There are lots of different things we can do to try to deal with detoxification. I'm going to cover this again. You guys had a whole day on detoxification essentially, but we'll talk about it in terms of the actual hormone balance. We've got to support both 1 and 2. And keep in mind that, the parent compound goes to these activated intermediates, which then you have to make water soluble so you can get rid of them. And the single most important thing that you need to remember about detoxification is please, please, please don't upregulate phase 1 first. You have to do phase 2 first, because if you get phase 1 revved up and they're not getting rid of it, you have not done her any favors. So specifically to estrogen, phase 1 are the liver enzymes that take estrone to the hydroxyestrone byproducts. And then phase 2 are the second phase that makes them water soluble. This has more to do with sticking something onto the molecule so you can get rid of it. And I'm going to go into the details in a second. Try to get the testing where you get a feel for both. Now, 2 and 4 hydroxy will both form quinones. Quinones are DNA damaging. This is more of an issue with the 4 hydroxy. For test 2 are the second phase that makes them water soluble. This has more to do with sticking something onto the molecule so you can get rid of it. And I'm going to go into the details in a second. Most important, just know your metabolites, keep track of them. Phase 1 detox, if you were to stop here and not do phase 2 very well, you're going to be doing damage to the DNA and RNA. And this is just a quick aside. There are some specialty labs that offer testing for phase 1 without giving you phase 2, and I don't really think that that's very helpful. So try to get the testing where you get a feel for both. Now, 2 and 4 hydroxy will both form quinones. Quinones are DNA damaging. This is more of an issue with the 4 hydroxy, less of an issue with the 2, because as long as phase 2 is working, it's pretty easy to just get rid of the 2 hydroxy, so you don't have to worry too much about it. 16 hydroxy is considered more problematic. It's much stronger in action. It's almost as strong in action as regular estradiol. So 2 hydroxy is the lesser of all evils. We want to sort of push things to that direction. But again, phase 1 is only half of the picture. You need to make sure that you get phase 2 going as well. This is basically sulfation, methylation, and glucuronidation. With sulfation, you need to make sure that they have enough sulfur donors in their diet, so all the alliums, garlic and onions and that kind of stuff. Methylation, we're going to talk about in 1 second. And then glucuronidation, just be aware that there are some pretty significant SNPs that could damage the person's ability to glucuronidate appropriately. You won't know that unless you test. But if somebody has Guillain-Barré syndrome, assume that they don't glucuronidate very well. All right, here's the folic acid cycle and methylation. You guys probably have already seen this, but if you look at it from the point of view of estrogen, estrogen is now the methyl acceptor, okay? And the red arrows are simply pointing out all the different nutrients that are necessary to keep this cycle going. And the whole point of the slide is to point out to you, these are the nutrients that she needs to have in her diet to make sure that she methylates correctly. And this is why we don't give B vitamins just like one or the other. They'll need things like betaine, which is trimethylglycine, SAMe, B12, 5-MTHF, B6, B2, and magnesium. Okay, phase 2. Each of these enzymes, the first set in phase 1, those are liver enzymes. The second one, COMT, will take 2-hydroxy to 2-methoxy. That's a protective compound. It takes 4-hydroxy and neutralizes it to 4-methoxy. You glucuronidate the quinones and neutralize them to mercaptates, and then you reduce 16-hydroxy to estriol. Yes, you actually have to remember all of this. You learned it once in biochemistry. You just have to learn it again. It's not that hard. We tend to measure ratios because they're such a different complex system woman to woman that if you look at a ratio that can actually be more helpful. This is a good example of how the 2-OH looks okay, the 16-OH looks okay. If you just look, hey, they're both in the green, isn't that nice? But the ratio is way off. So that's why it's important to look at the ratio. Now, low 2-to-16 ratios, what are the possible causes? These are all things you need to keep track of. And I don't know about you, but I have patients in my practice who have every single one of these things, right? The obese person who's stressed out, drinks too much, has rheumatoid arthritis, is a non-organic gardener, has a crappy diet, and is on birth control pills. So, this is not an uncommon patient all at one time. Now, alcohol in women, alcohol is metabolized through the same SNPs as estrogen, so it competitively inhibits. And basically what you need to know is that there's essentially not really any safe dose of alcohol that would be 100% safe. All the studies have found an increased risk of breast cancer associated with increasing alcohol content. And the main thing you also need to keep track of is when a woman says she has a glass of wine every night, you might want to ask her how big her glasses are. Seriously, you go to Europe, they have these little, my husband has his great-grandmother's china and dishware. Her wine glasses are like our cordial glasses. And her water goblets are the size of our other wine glasses. So it's sort of like a cup of coffee. You know that a cup of coffee is actually 3 cups because it's a mug. Same thing with wine. Enterohepatic recirculation. This is basically just to remind you that what's going on in the gut is really important. And interestingly, there's a difference in renal excretion versus gut excretion of estrogens, whether you're an omnivore or a vegetarian. Because vegetarians have so much more fiber in their diet that they tend to bind up a lot of estrogens and get it out through the GI tract, and omnivores get rid more of it through the kidneys. I think that's kind of interesting. Intestinal excretion, we've actually kind of covered already in a couple of the other talks, but basically keep track of lipotrophic factors, lignans, probiotics, and more fiber. Beta-glucuronidase has already been alluded to today, but essentially if your microbiome is not functioning correctly, it's going to be elucidating this beta-glucuronidase. You take your conjugated estrogen that your liver worked hard at to get rid of, it gets into the stool, the beta-glucuronidase flops off the glucuronide portion, it now releases the free estrogen, goes back across the cell walls, back into the system, and if this is a menstruating woman, her ovaries have no idea that this is happening, so they're not making enough progesterone to cover it. So keep that in mind. Estrogen dominance. We're going to go through this relatively quickly because we've kind of already covered some of this. These are the symptoms of the estrogen dominant woman. Basically, most of the time, she feels bloated and fat and irritable, has headaches. That's really kind of, if you see a patient like that, just kind of assume that they are estrogen dominant. If they yell at people or cry at stupid things on Facebook for the 2 weeks before their period, she's estrogen dominant. This can be relatively high estrogen compared to progesterone. They may still actually be within the normal limits. There's no real consensus on what an ideal ratio is, so don't try to figure that out. It's really more about symptoms and how they feel. Causes of estrogen dominance premenopause are things like you're not really ovulating because you've got PCOS, or you're having multiple ovulations in one cycle, or the whole cortisol steal picture. Could be from environmental issues, could be because of increased BMI and the fat is producing more aromatase. Could be all of those things. Now, can you be estrogen dominant in menopause? Yeah, you can. Now, it's totally different causes. Could be your genetics because you don't get rid of your estrogen well. So even though the overall levels are lower, they're still not balanced and you're still estrogen dominant. It could be, again, from aromatase because you're inflamed and obese. It could be the stress is inducing lowering of adrenal progesterone. So you can still be estrogen dominant even in postmenopause. So we've kind of already covered this. An interesting point that a postmenopausal obese woman can have 40% increases in circulating E1 and E2 compared to normal BMI women. So that's pretty significant. So, look at their waist to hip ratio. And if you can get a bioimpedance assessment done, that's even better. So for transport, what do we want to do for somebody who is estrogen dominant? Well, how did they get estrogen dominant? Under transport, if they have lower sex hormone binding globulin, that's going to give them more available estrogen. There is an association with red meat consumption, and I couldn't tell in the way this paper was written whether this was from conventionally raised cattle or not. But the women in the highest quartile of total red meat consumption showed 13% lower sex hormone binding globulin. I'm guessing it was because these were conventionally raised animals and they had a bunch of hormones in their system. Might not exactly be the same if these are from pastured and pasture-finished cows. Don't know. Think about estrogen, endocrine disruptors. That's a cause of estrogen dominance because they are estrogen mimics. And also, these mechanism of disruption can be that they bind to hormone receptors differently. Normally, hormones sort of hit the receptor, hang out for a second, and leave. But the organic pollutants hit on the receptors and stay there. So you're getting consistent consistent receptor stimulation. So it's a totally different picture than what would normally be happening. So that's probably why it's such an issue. All right, let's move on to luteal phase dysfunction. This slide, and I apologize, this is it looks a little weird because it stops on day 21. I mean, you do realize that it's supposed to go up and then come down. But the point of this is that with luteal phase dysfunction, you get very, very small amounts of progesterone being produced. Now, what does progesterone do? Progesterone is our friend, okay? It downregulates estrogen receptors. It inhibits the transcription of estrogen receptors at the DNA level, increases cellular differentiation. It promotes apoptosis. It inhibits uterine activity. That's a little clinical pearl. If somebody tells you she suddenly is having cramps and her bleeding pattern otherwise hasn't changed, she didn't have enough progesterone that month. So progesterone is our friend. Now, you guys are probably aware of this, but I always feel like I have to say it. Progestins, progesterone, totally different. Progestins are usually human-made molecules that have action that is similar to progesterone, but they are not the same thing. And generally speaking, when you see it in the literature, you have to actually read the material and methods section of the article because I've seen many papers where they use the word progesterone in the discussion, the abstract, and the conclusion, but if you read the materials, it was a progestin. So be careful about that. It's one of those things that I really have to keep pointing out to people year after year. Luteal phase dysfunction is really about inadequate progesterone secretion by the corpus luteum. You get a shorter luteal phase, so the cycles will be somewhat shorter in length. Or you'll get that bleeding pattern where she'll go, well, you know, I like spot for a couple of days, and then I'll get some real bleeding, and then I'll spot again at the end. Anybody who says that didn't have enough progesterone. Really quick, simple clinical pearl. And there's a small portion of these women who actually have luteal phase dysfunction who still have perfectly normal, regular menstrual cycles. Go figure. Talked about this essentially, so I'm not going to go through it again. Now, causes. Lots of this is dietary. Excessive exercise. I see this a lot in my practice. This is from cortisol steal, because these women are trying to get healthy. My favorite patient is a competitive CrossFit person who also is a trainer. Her cortisol was off the roof, and her progesterone really tanked. She really messed up her luteal phase. And that made her gain weight and get inflamed. So, cortisol steal, I'm not going to go into it again because we've talked about it all day, but just keep this in mind as a problem with any kind of progesterone production. And PCOS is essentially estrogen dominance plus luteal phase dysfunction. And this was already talked about, so I'm not going to really go into it in detail. Don't freak out about the details on this slide. Basically, just think of it this way. If the cascade on the right of the slide is what's going on, we don't start at the bottom to fix it. We treat upstream. We always go upstream first. And in this case, you're going to have to treat, and when you're treating luteal phase dysfunction, you pretty much are going to have to treat based on symptoms, not on lab work. And again, go to underlying abnormalities first. I usually start with a plant called chaseberry, Vitex. If that doesn't work, I'll move on to progesterone. And if you're going to use progesterone, this is the time to use bioidentical progesterone. And generally, this is probably one of the few hormones that I still use orally because it can be really helpful. So that's a possibility for treatment. Now, in fluctuations in hormone levels, this is really all about like perimenopause or from big stressors or just like PMS. And again, remember, it's about changing levels, not absolute levels. That's where the symptoms happen. PMS, for instance, we're going to talk about PMS at the end of the talk, so I'm not going to go into details here. But there's lots of different symptoms. They're sort of heterogeneous because that's the way the hormones are. And so PMS for one woman won't look the same as PMS for another woman. And the symptoms will overlap. Hormone insufficiency. Well, this is basically, think about chemotherapy, think about autoimmune premature ovarian failure, think about surgically induced, obviously with an oophorectomy, but also remember tubal ligations have been known to damage blood flow because of the redundancy of the blood flow in the pelvis. It could be also from just, perimenopause, menopause. Suboptimal hormone metabolism. All right, we're going to go into a little more detail here. The ATMs here are primarily SNPs. These are things to keep in mind. SNPs, how does she eat? How is she stressed? Is she overweight? How inflamed is she? Is she exposed to endocrine disruptors? And that we just went through. Here's a summary of all the different things I just said about the patterns. Laminate it. Keep it next to you when you're dealing with hormones, just so that you can remember what to look at, the different drivers that you might be needing to check off. Okay, time to go into lab testing. There's a lot of problems in measuring hormones, and I'm just going to do a little quick aside. We've expanded this section of my talk because when you come to do the hormone module, there's an entire hour webinar that you do before you come just about lab testing. So I obviously can't go into the whole thing right this minute, but I wanted to give you the slides So as we go through the next little bit of slides, I'm not talking about all the details, but I just wanted you to be aware of the problems. And if you were at the lunch talk, he sort of referred to some of this as well. The issue is hormone levels fluctuate. So like, how are you going to be able to measure them correctly? A lot of the studies of what we are considering normal hormone levels, well, they're older studies. The methodology was unreliable. They often were averaging non-comparable groups. Different labs have different reference ranges. And then there's the whole issue of what are you actually measuring? I mean, there's the estrogen pool. Sorry, I went too fast through that. There's all these different kinds of estrogen. So with different lab tests, what are you actually measuring? Are you measuring the metabolites? Are you measuring just production? Are you remembering to measure what's bound, or is that all you're measuring? And, you know, this progesterone, it varies all throughout the cycle, so how are you going to be able to get the measurement? These next few slides, I'm not going to go into all of the details. They were put together by the wonderful IFM staff, doing the pros and cons of different hormones and different modalities. Basically with estrogens, good news about testing with serum is it measures the endogenous hormone production. There's decades of good validation. For estrogen metabolites, and this goes for both estrogen and estrogen metabolites, the downside is the levels you're going to get are going to tell you both the bound and the free together, so you don't know what the patient's actually seeing. You don't get a free estrogen, free estradiol. The rest of that is a bit problematic with the serum as well. Now, the saliva, it's non-invasive. That part's good. It's great for serial measurements across a whole month if you want to see that. You would not want to go in and get your blood drawn every single day for a month. And the salivary estradiol does correlate well to the free estradiol in the serum, which you're not going to be able to get on a serum measurement. There are some issues, downsides to doing salivary levels. 24-hour urine and spot urine can be helpful. I just want to make a comment about the spot urine. There's fewer validation studies in the spot urine because it's a newer technology. And that I'm going to skip. The progesterone, there's literature to support using a serum progesterone level as a method of confirming ovulation. That's really about the only thing that's in the literature. The reproducibility of this is really limited at low serum levels, so you have to be careful what time in the cycle you're drawing them. In the saliva, it can be, you know, it's got all the same things. It's non-invasive, it's convenient. There is some cross-reactivity with immunoassay results, and there is rapid fluctuation in the saliva, so that may mean that you're going to have to take a bunch of different samples and kind of average them. And same issues with 24-hour urine. The metabolites are really what they're picking up, but we're not really sure what that means necessarily, so you have to be careful with evaluating urine progesterone. And if you're trying to do testing for progesterone treatment, this is where you really get into trouble. Transdermal progesterone, you can't get any kind of testing that makes any sense. Serum doesn't make sense, saliva doesn't make sense, urine doesn't make sense. So if you're using transdermal progesterone, you have to go by symptoms only. Serum test is also problematic because progesterone is metabolized so fast that the serum level may not really mean much of anything. So again, you know, what are you looking at? So it becomes more of a problem when you're having to deal with following somebody who's on hormones. And I'm going to kind of skip through some of these because it's actually already been talked about with other speakers. But you can go back and look at those details.